everybody, Dr. Rob Silverman here, Proven Health Alternatives. I have Dr. Melody Hartzler. Got that correct? Said that right out. She's
Yes.
a functional medicine expert. She owns and runs an online functional medicine school. I've had the luxury and the honor of being able to lecture. Her background is a pharmacist, and she's going to add some interesting insights to a lot of different things because of her extensive background. Doc, my pleasure. How you doing today?
Yes. Thank you. Thanks for having me. I'm doing well.
I'm happy to have you. So let's jump right out of the box. Metabolic disease is the disruption of the body's ability to convert food and drink into energy. Less than
Yes.
7% of Americans are metabolically healthy. It's actually 6.8. The most common metabolic disease, diabetes type 2. Over 50 million Americans have metabolic disease, and the prevalence of type 2 diabetes will increase by 54% by 2030. Unbelievable, right?
Crazy.
So,
Yes.
begs the question, what causes metabolic disease?
Yes, so there's a lot of factors. And so there's a famous endocrinologist called Ralph DeFranzo. His name was Ralph DeFranzo. He's still alive, but he coined the term the ominous octet. And so it was like the eight things that caused, or that more like eight outcomes of what was going awry in diabetes. So it was talking about the insulin resistance and the signals that the brain is not receiving from certain hormones. But I think in the endocrinology community, it wasn't until there was another endocrinologist that wrote a paper that coined the egregious 11. So it was these 11 mechanisms that caused diabetes that they started to identify
Wow.
more about the gut, and also more about toxins were even mentioned when they were talking about those things. So I think when we think about it from a functional medicine standpoint, we think about toxic components. We think things, even things like arsenic, which are common in lots of things that are grown in the ground, like rice. We also see it to be in pollution and other sources. We also know that certain chemicals induce insulin resistance. So we know for sure that the veterans that were exposed to Agent Orange in Vietnam were seriously, like very severely insulin resistant, to the point where when I was a resident at the VA in 2010, we were using very large doses of insulin for those patients because this was pre-GLP-1 drug era, which were those drugs that helped us to use less insulin. So at that time, we were using 5 times as concentrated insulin in a lot of these veterans because of the insulin resistance that they had because of that chemical exposure. So what other chemical, there's so many other chemicals that we're exposed to on a daily basis. We've got people working in factories. I've had people come in that I'm like, oh my goodness, they must be type 1, right? Like they're
Right.
skinny, they don't have any other signs of metabolic disease, but they're not. They were completely insulin resistant, likely due to toxic exposure. So that's one piece of the puzzle. The other piece of the puzzle, obviously, there's genetic components, right? Family history plays a role. But we always say family history is not everything. You have the
Right.
ability to change how your genes are expressed with your nutrition and your exercise. But I do think the microbiome is also a huge player here, because we know that certain bacteria strains produce what's called short chain fatty acids. And short chain fatty acids are helping to stimulate our endocrine processes, particularly even stimulating that GLP-1 hormone. That's the hormone that we should be secreting when we have meals, and it tells our brain that we're full. It also tells our pancreas to make insulin, and it helps to improve the insulin sensitivity in our body. And so if we're missing that hormone because we don't have these signals, even, and some of the microbiome actually even stimulates GLP-1 outside of the short chain fatty acid process too, certain bacterial strains. And so that piece, and I think about like now we are here in 2025, how many generations have had exposure to antibiotics at this point, and how
Mm.
much microbial diversity has changed in the period of, not just my parents and my grandparents, but even my great grandparents maybe had exposure to antibiotics. And now it's just like you get it anytime you're sick, oftentimes. And so when we look, we're often looking at stool tests of patients with metabolic syndrome, and their diversity is not there. And I'm sure you see this too. There's just very
Yes.
much a lack of
Beautiful.
diversity. So I think that's a big component. Intestinal permeability, because of that lack of diversity. And then we get certain bugs overgrown that contribute to more inflammation in the gut and can cause it to be more permeable. There's actual data linking intestinal permeability to and pancreatic inflammation, which also affects the insulin cascade. So it definitely is, gut related, the toxin related, and then there's even nutrient depletions that are playing a role. And so there's, papers talking about zinc and and zinc deficiency. And I think that one's sort of under assessed in our general population. A lot of people are looking at
Agreed.
vitamin D deficiency now, which we know is leads to poor insulin function. I had someone that had their vitamin D tested this week, and he's gone to endocrinology, he's gone to primary care. I finally got him to go to labs after like 6 months of working with me. His D level's 13, and so of course he's going to have trouble with his insulin regulation with a severe nutrient deficiency like that. But zinc plays a role in not only insulin signaling and immune function, but it also plays a role in the Krebs cycle and just creating energy. And so when we think about mitochondrial health, zinc has all kinds of roles in the body. So there's actual studies of patients with prediabetes that were given, so half the group was given placebo, half the group was given zinc, and the group that was given zinc did not progress to diabetes as often as the group that was taking placebo. That group also lowered their insulin resistance markers and their CRP, which is their inflammation, because of the better control on their blood sugars and just how zinc works in other areas of the body. But then there's other nutrients like magnesium, chromium. We've even got our fatty acids that can promote, we get more inflammation when we have deficiencies in omega-3 fatty acids. But the mitochondrial piece, also CoQ10 is a big thing, and statin medications, which often this crowd of people that have this insulin resistance, their lipids start to increase and then they get put on a statin medication. Well, then the statin medication, while it has some anti-inflammatory properties and in some populations may be the best thing for them because of that anti-inflammatory, we have data that reduces, risk of heart attack, especially secondary prevention. Not as we don't have as much data on primary prevention, but the secondary prevention, if they already had a heart attack or stroke, we have more data there. So I'm not saying everyone needs to stop the statin, but it's a question of, do you need to make sure you supplement with CoQ10 if they are on that statin, at least 100 milligrams a day, if not 200 or more. But that CoQ10 depletion, I do wonder if that's part of the mechanism for why when we put patients on statins, we get an increased rate of progression to diabetes. Likely there's already some foundational other things going on, but then you decrease that CoQ10 more in the mitochondria. But there's also some microbiome changes with statins as well. Some papers written on that. So I think they're still sort of learning and it is probably, like I said, a multimodal type mechanism. But it's interesting. And I think something that needs to be further studied, because when we're giving something to someone, for this potential benefit, we want to make sure that we're not worsening another risk factor that they have in the metabolic arena.
You see me brimming from side to side because so many good things, and many of which revolved around the gut. As everybody knows, the
Hmm.
gut is the epicenter of your health. I've got a study here that talks about Harvard Medical School discovered that certain species and strains of bacteria and certain viruses, pathogens, are
Hmm.
associated with alterations in the gut's microbiome function and increasing the individual's risk of developing type 2
Hmm.
diabetes, to echo what you said before. So
Yeah.
obviously, leaky gut is a problem. Leaky
Yes.
gut poses an interesting complication. Most times, a patient will walk into the doctor, they won't talk about the gut's effects, certainly on blood
Mm-mm.
sugar, certainly on diabetes, etc.
Yeah.
Now, you talked about antibiotics. They are the nuclear weapon for the gut,
Hmm.
without
Yeah.
questions. I mean, they have no discernibility. They just blow everything up.
Right.
Zinc and magnesium. Magnesium and zinc, I should do it in that order. They are the two most important minerals, according to me, or in my opinion.
Yeah.
Magnesium is the miracle mineral, about 800 enzymatic reactions. Zinc is about 300. I guess if you and I filled in a third one, I'm going to go with selenium. What do you say?
Yeah, I think selenium is a good choice, especially from a thyroid standpoint. And we know people with insulin resistance often have thyroid dysfunction as well. So it's all we need. I think the biggest thing with like all of this is all your nutrients need to be at optimal levels for your mitochondria, which is that powerhouse of the cell, to work. And so often a lot of our studies are like one nutrient. So we're going to test vitamin D, or we're going to test B12, or we're going to test this. But like it's that nutrient synergy that really pulls it all together. And so I think that's where our modern way of like studying doing clinical trials only like one thing at a time does not work when we're doing nutrient studies, right? When we eat an apple, we don't just get vitamin C, we get quercetin and all of these other
Right.
polyphenols that are part of it.
Wonderful. So essentially, we all want to take our vitamin D levels, omega-3 levels, but we also
Yes.
want to take our micronutrient levels to see
Yes.
the full composite of what's going on.
Hmm.
Getting back to what you said before about the mitochondria, I think the
Yeah.
mitochondria function dysfunction now is without question a
Hmm.
hot topic, if you will. And it's
Yeah.
interesting how you brought up the idea of statins. Now,
Yeah.
my understanding of statins, and you are a pharmacist, so you'll know the
Hmm.
pathway better than me,
Yeah.
is that it breaks up the cholesterol particles and turns them into glucose particles.
So it actually blocks HMG-CoA reductase, which is an enzyme that produces cholesterol. And it happens. A lot of our cholesterol is produced in the evening. So some of the shorter acting agents, like our lovastatin and things that were more of our initial statins, had less potency. And so we'd have people take them at night to help block that overnight. But I don't know that it actually is turning anything into glucose. It's just blocking, and I could be wrong with that too. So I might have to go back and look at that and let you know before the editing of all of this. But yeah, so it's blocking actually the formation of cholesterol. But then there's other agents like ezetimibe that block the absorption of cholesterol in the gut. So sometimes if people, there's genetic mutations that can cause people to absorb more cholesterol than other people. So that may be a good route for somebody that maybe is just a hyper absorber of cholesterol is to block that in the gut. But we do turn, so like while why triglycerides get high in patients that have metabolic syndrome is
Right.
from that excess glucose for sure. So that, profile, you end up seeing it's not a lot of times from a dietary standpoint, when someone fixes their glucose and they fix their, excess sugar problem, then their cholesterol gets better. But that's sort of not what's been preached over the last decade, right? It's been preached that you should eat low fat and that's going to result in better outcomes. But in general, that doesn't happen, right? People eat low fat, they end up eating more sugary carbs or fake
Right.
foods, and then their cholesterol profiles worsen.
One more thing about statins from a chiropractic perspective, statins have robust data that they damage intervertebral discs in the spine. They
Hmm.
also increase the incidence of muscle pain. So, as a chiropractor, when somebody
Yeah.
comes in, that's a standard question. Are you on a statin? So, let me segue
Yeah.
into the natural options for statins.
Yes.
Red
Yeah.
yeast rice, as you
Right.
said, cytochrome P450 functions at the same enzymatic reaction level in the liver
Yeah.
in phase one of the liver as a statin. So
Hmm.
I'm not saying not to use it. However,
Yeah.
it's a statin.
Right. Yeah, red yeast rice is definitely so that's really where the statins were born out of, was this mechanism again blocking that HMG CoA reductase. And then because they block that, which is part of like the cholesterol precursor for the cholesterol synthesis process, it leads to like lower endogenous cholesterol production, but then also upregulates as your cholesterol decreases, it upregulates LDL receptors, and then that helps the body to get rid of extra circulating cholesterol too, which then is why we see less blood cholesterol levels. But you're right, red yeast rice has the same mechanism, probably not to the potency level. And I think like what's been explained to me, I've listened to Mark Houston talk about this before.
Yes.
He's a cardiologist in this space. Is that with red yeast rice, you're also getting like sort of like that apple example, you're getting the whole plant. And so you're getting some antioxidants and some other pieces instead of just that one particular compound that is inhibiting that one enzyme. It's sort of a multimodal mechanism. So I think that's where some people find it to be safer, less risk for the muscle pains. And some of that muscle pain comes from that CoQ10 depletion. So there are studies that if we put CoQ10 on board with the statins, that it helps to reduce the muscle pain and people can continue the statins or the red yeast rice. But we do have to be careful about red yeast rice because there's like a toxin that can be associated with red yeast rice. You have to make sure you're choosing a good product that has been tested for that.
And one more thing on coenzyme Q10, number one nutrient in heart muscle. So when you take a statin,
Hmm.
you deplete that, damaging the mitochondria. The heart's probably the second most abundant mitochondrial organ.
Yeah.
Metabolic disease to metabolic syndrome. One
Hmm.
third of America has a metabolic syndrome. Would you like to go through the five criteria of metabolic syndrome? Well, actually, three out of five.
Sure, sure. Yeah. So if you think, and I always think about this when I'm traveling and I'm in an airport, I'm just like people watching, like
Mm,
how many people would qualify for this metabolic syndrome? But abdominal obesity is the one of the core
right.
pieces. So people have a waist circumference over 40 inches in men, over 35 inches in women. So you can measure your own waist circumference to determine if that's you or not. Often comes with an elevated blood pressure over 130 over 85, or they're already on a blood pressure medication. Elevated fasting glucose above 100, which is a pre-diabetes. So anything less than 100 is considered normal, although a lot of us in the functional medicine community would argue that your fasting really should be
Right.
70 to 85 in the morning. And if it's starting to creep up to 100, that's an early warning sign. But the technical definition is pre-diabetes or diagnosed diabetes, which diagnosed diabetes is when your fasting is above 126, or your postprandials start to get above 180, which is that after meal blood sugar. And then the triglycerides. So having a triglyceride level greater than 150 is a sign of, because of that excess glucose turning into triglycerides, that is a marker. And you can even see that starting to creep up too when it starts to get over 100. That's sort of my sign. Okay, you're not at an optimal metabolic state. And then low HDL, which is often termed as that like healthy cholesterol, but that is less than 40 in men or less than 50 in women. That is sort of the marker. So you have to have at least those are like three of the five criteria. So either abdominal obesity, blood pressure issues, glucose issues, triglycerides, or the low HDL. And so really, again, driven by this insulin resistance mechanism, inflammation, this nutrient depletion, all these things we're talking about.
Yeah, 3 out of 5 of those. And a real big takeaway, which I think you alluded to, is if you take a medication to mitigate one of them, it counts as a
It's
checklist.
still, yes, exactly.
And when you think about it, it's not that hard to get the 3 out of 5.
Right. Oh, yeah. In the average population, absolutely.
75% of Americans are overweight or obese. More than 50% have some form of blood sugar dysregulation. I just
Mhm.
think that the model, or if you will, the medical model, has played with the numbers enough not to captivate enough people, or it's caught up to where we are with the blood
Sure.
sugar issues.
Yeah.
I think if you had a practice just on metabolic syndrome, I think you
Mhm.
would be super busy. Not you, but people in
No, I
general.
do. I actually co-own a clinic called the Integrative Metabolic Center, and
Wow.
it's in Dayton, Ohio. And so, yes, I mean, I think that we, if like, we're never going to go out of business as long as the food industry is continuing to
Sure.
serve what it does, and we just don't, if we don't get this together from a nutrition standpoint, I think that's the biggest key, especially starting with kids. I mean, the fact we were talking this morning with my physician colleague about kids and having the fatty liver in children
Mm.
because of high fructose corn syrup. And so it's just crazy. Like that. So we're talking about like liver health and how to prevent fibrosis, and they're talking about this with teenagers, right? And it's like, how are we at a place where this is a conversation?
I agree. And of course, fructose is interesting in that I've had Dr. Rick Johnson on, and he made a statement. He said, fruits are okay, fructose isn't okay.
Hmm.
So moms are listening, dads are listening. Sugar, yes or no? And if so, which sugar is okay?
I mean, I think no soda whatsoever should be
Mm,
consumed by children. Absolutely. I mean, honestly, adults shouldn't be consuming soda either. I do think juice is causing a problem too because we're getting more fructose. And when when we actually eat the fruit, we get the fiber and other nutrients that help slow
right.
it down. And so we don't get quite the sugar spike that starts to cause some of these problems. And so, do I let my kids have an apple juice on a vacation? Like, yes, once in a while. But should that be like a regular part of their daily nutrition? No. I would rather them, honestly, I would rather kids drink a glass of milk a day than drink juice because they're getting
Okay.
protein and healthy fats and other, components. So I think that, in general, juice is probably a no-no. I mean, in our house, our kids drink water. For the most part, we might have a sparkling water, like a Spindrift, which has like a tiny bit of juice in it to flavor it, which I prefer over some of the artificial, natural flavoring type things. But in general, most people just need water. And if your kid's struggling on the weight scale, maybe a little bit of whole milk or grass-fed milk, if they tolerate dairy, I think is, my son is super active, and sometimes we can't feed him enough calories to like keep him growing. So that's one thing. But yeah, so I say most people do not need juice in their diet. But then if you are an adult and you have metabolic syndrome, then we really probably don't need milk at that stage Because I always tell my patients, I used to do more of a conventional practice where I just saw pa diabetes patients after diabetes patients all day long. A lot of them were farmers in a farming community, and they're like, "Well, I drink 6 glasses of milk a day or 4 glasses of milk a day,"
Wow.
because that's what they did as a kid, and that was fine as a kid when you're running outside and doing all these things. But like milk has the exact ratio of nutrients for you to grow, to stimulate growth hormone. It has
Mm.
growth hormone in it from it's like a mammal nourishing another mammal to help it grow. So we don't need that as an adult when you're finished growing.
So if I wanted to add some stuff to my Java Joe,
Yeah,
would it be regular milk? Would it be plant milk?
plant milk. I think that's a trick question.
No trick questions here. No, the reason I ask you
Yeah.
is because, a lot of people want to know what to fill with their
hmm
coffee.
Yeah.
They've got the type 2 diabetes or they're scared of it.
Yeah.
Which one would be more health
Yeah.
beneficial for that scenario?
Yeah, I mean, it probably depends on like the personal situation and like if they have any food sensitivities, like if they're sensitive to dairy and it's causing them inflammation, then that's probably not a good choice. So checking to see if you have GI symptoms or you have other things going on, like are you reacting to certain things? I personally use organic soy because it has some protein, and it has some carbs as well, but it for me, I don't tolerate dairy very well, and lactose I don't do super well with the milk from a gut standpoint. So I choose that, but like a lot of people are choosing like oat milk or some of these other things. I mean, nut milks might, but it's probably best if you like make it yourself, versus the
Without
ones that have a lot of
pasteurized.
the gums and things like that in it. I've been able to find at my Whole Foods like a soy milk that's literally just organic soybeans, and not anything else. Now, it doesn't froth as nice as the silk version of soy milk
Right.
because of the doesn't have the gums, but it works. But yeah, so like oat milk in particular, I mean, it makes a beautiful latte, but it has a lot of the pesticides in it, which some are connected to insulin resistance. You're also getting a pretty big glucose spike, from oat milk. So I would say if people are choosing a non-dairy, like doing a coconut or a nut-based or a soy would be more, as long as they're not reacting to it from a food sensitivity standpoint, but that would be good.
Yeah, if I had to use a nut milk, it would be almond. And I got a new one that was great. My wife made it was pistachio nut.
Ooh,
Outstanding
that
as
sounds
far
like a
as
good
taste.
latte.
Yeah, yeah,
Yeah.
I like a latte too. It's interesting that we talk about what people can eat, and you and I both know that once you take away something, they feel
hmm
like you took away their hope diamond.
Right.
And it's not the case. The idea of eating on a scale of good, better,
hmm
best.
Yes.
So the best would be probably avoid the plant milks. The better plant milks would be the ones that we aforementioned, and good
Yeah.
would be the dairy because
Yeah.
there's a lot of argument in the field about dairy, certainly
hmm
amongst adults.
Yeah.
Insulin resistance is a
Yes.
condition in which the body cells do not respond properly to the hormone insulin.
Right.
How does this contribute to metabolic syndrome?
Yeah, so the hormone insulin is secreted in the pancreas, by the beta cells, and so that hormone should go and tell so that should rise after we eat, which partly is that GLP-1 telling the pancreas, hey, we've eaten, there's food here, and it tells the pancreas to make insulin. But then insulin should bind to receptors on the liver and tell the liver to stop, secreting extra glucose. So the liver's job, it's the fancy term is hepatogluconeogenesis, but it's basically like the production of sugar from the liver when we're in the fasting state. So what happens is that because insulin is binding to the liver and the message is that resistance to that message is not happening, then we see this extra glucose. The liver is just putting out all this extra glucose. So we have patients waking up in the morning that haven't eaten for 10 to 12 hours, but their blood sugars are still high. And that's really that liver continuing to produce blood sugar and not responding to that insulin. But insulin also is every cell needs insulin to drive the glucose from the bloodstream into the cell. And I always used to explain it to my patients when I saw a lot more diabetes patients, that it's like a lock and a key. So insulin's like the key that unlocks the door and allows your, glucose to go from the bloodstream into the cell. And so when you are not getting that, it's sort of like an old rusty barn door when you have insulin resistance. So it opens up a little bit. Some of that glucose is going in because you're not passing out, right? You're not, completely out of it, but you're not getting that full energy into your cells. So a lot of this insulin resistance, again, is people feel really tired when their blood sugars are high. It's because their blood sugar or the sugar is in the blood and not inside the cell being used for energy. And so that's what's happening in the system, is that you've got this excess glucose. And then when you've got excess glucose in the bloodstream, you're starting to damage the cardiovascular system cells. You're starting to damage the kidney cells. And there's this increase in reactive oxygen species. And even when people are going like high to low and high to low, that contributes to that increased inflammation. And so then you start to see more blood pressure issues, more kidney issues. And so it's really interesting, even in this. So GLP-1 medications are the semaglutide, the dulaglutide, tirzepatide, those medications that you're hearing in the news that everyone's trying to get for weight loss. But those are mimicking that GLP-1 hormone. So they're telling our brain that we're full. And it's not at like the level that your GLP-1 hormone is naturally produced. It's a super therapeutic level. So it's a really high response, and at the pancreas telling the body to make insulin. So, but with those, the effects we're starting to see not only on heart risk reduction. So we see people have less heart attacks, less strokes because their blood sugars are more stable with these medications, but also probably some other mechanisms that GLP-1 has in the body. But then there's even new kidney data showing people that are on them versus not on them actually preserve their kidney function. So this whole like process of this hormone, and I think we talked at the beginning before we started recording that like some people would be they'd be good candidates for those medications because
Right.
maybe they are very overweight, and getting their weight down will help improve their blood pressure and some of these other cardiac risk things, help them walk better because they need to lose 100 pounds to actually be able to feel good walking because their knees hurt so bad. And so sometimes they can be really good tools, but the state that we're in where like everyone qualifies or everyone needs one is probably not a good place, because a lot of people that maybe just need to lose 40 to 50 pounds, like we need to work on all these other underlying causes. There's also a big piece of trauma, and people having traumatic childhoods. You've probably talked about ACE scoring in the past, or average childhood events.
Mhm.
But when people are exposed to traumatic things as children, they're way more likely, and I can't remember the number off the top of my head, to be obese in their future. And so sometimes it's more than just the numbers, the nutrient levels and all of these things. Sometimes we have to actually like help them process the trauma, even if it was years ago, to be able to eat in a regular manner, because maybe they're binge eating or they're avoiding food and they're not nourishing their body because of different things that have happened in the past. So, and really, we didn't talk at all yet, which I can't even believe, about the HPA axis, but there's like that dysregulation of the HPA axis, which is that stress system and that fight or flight system that we have, that because of past trauma, that can be dysregulated. And then they're just constantly in this fight or flight, and cortisol starts to increase. Cortisol tells us to, store our fat in our abdomen, which creates this abdominal obesity. So even that piece of it is getting people out of the fight or flight and getting them into that rest and digest to really start the healing process.
You know, I got the greatest job in the world. I do, because I get to interview guests who are not only interesting, but are just full of knowledge and share so many good knowledge bombs. That was great. I mean, I could imagine if we were live, how everybody's like, wow.
Yeah.
Is that I'm having that wow moment. So
Good. Mm.
no, it's great. It's just great to share health, because America really needs it.
Yeah.
We're an unhealthy state, an unhealthy union, if you will. To get back to the insulin resistance, and I'm going to
Yeah.
roll in back into the GLP-1, because
Yeah.
how could we not like
Yeah.
close a loop on that? So the insulin resistance, I just look at it as like a lock and a key, and there's no
Hmm.
Velcro in the
Yeah.
cells, so the blood sugar floats around. And I will
Hmm.
say this, I think one of the most detrimental inflammatory markers is insulin resistance and high
Yeah.
blood sugar, much worse than any kind of cholesterol marker, etc.
Yeah.
So as far as the GLP-1, I love it because it talks about my favorite axis, the gut to brain axis. I
Yes. Yes.
love it because it incorporates mitochondrial function or dysfunction.
Hmm.
Mitochondrial dysfunction causes GLP-1 signaling to go down. Leaky
Yes.
gut causes GLP-1 signaling to go down. GLP-1 communicates with the brain, so you have pre-ingestion satiety. But the GLP-1, if you were to look at a figure, it communicates with all these different organ systems. So, we've always said the gut is the epicenter of your health. The great hot example right now is GLP-1. Just wrote an
Hmm.
article that'll be coming out in about a month on GLP-1 alternatives or natural alternatives.
Yeah,
As you said, nobody's anti-medication. It has its place, but it's
sure.
probably not right for everybody. The medication is though right or conceivably right for those who are morbidly obese, who have tried everything. If you're 20 or 30 pounds overweight, do it naturally
Right.
because either way, you need a lifestyle. And one of the downsides to the GLP-1 is the weight loss is 40%
Hmm.
coming from muscle mass. Muscle mass is your longevity organ, Dr. Gabriella Lyons.
Yeah.
That said, obviously, organs like your heart are a muscle mass. I just read an article, just to wrap this up in a nice tight bow, that the average person loses 10 pounds a year of muscle mass and bone on Ozempic, but normally would only lose a half a pound. So it's 20 times the increase of loss of vital tissue. So no one's saying not to take that, but put that in the equation.
Yeah, and I think, and I can link you some of the publications that looked at like DEXA scans in patients. So looking at like the DEXA to be able to look at the muscle versus fat loss, which is a little different than looking at just the bone that we're used to using DEXA scans for. But there's really like, if you lose that amount of weight, no matter what method you lose the weight in, you are going to lose some muscle mass. You're going to lose
Mhm.
water.
Without question.
So I think it's not as much like how you lose the weight, but that you lose this drastic amount at once, which isn't as common unless someone's doing bariatric surgery or the medication. And then when we're, given the medication like this and you lose very quickly, that's probably more of the piece of the puzzle than if we're just like slowly building muscle and losing fat over the time. And I think part of the biggest piece of this is now you're telling your body that you're not hungry, but you also need to eat protein, right, to maintain muscle mass. And so when you
Right.
eat less, and especially if we're giving these to patients that are elderly and maybe at risk for sarcopenia and things like, because they're not moving as much and all of those factors, we do have to think about really driving home, like when you eat, you have to eat protein first and you have to eat vegetables, because if they're just like, oh, I find it suppresses the appetite so well that then people are like just eating carbs because they're just wanting sort of like the comfort foods. And so I think if we're using them as the correct tool in, obesity medicine, we need to be having those conversations about you need to be lifting weights, you need to be, eating protein to help patients be successful on it. And maybe if you have the capacity in certain patients to do a DEXA scan or to use some of the other technologies that can measure your fat mass and things like that, like there's certain scales that are correlated to DEXA. So if they can use that to monitor, I think that's really important too. So making sure you're working with a provider that can do that versus someone that's, just sort of like, hey, here's your med, see you later.
I think you're echoing what's been said
Yeah.
many times on this podcast
Yeah.
is ring the bell, hit the bell, like in the circus where the guy comes
Hmm.
in or the carnival where it hits the
Yeah.
bell and everybody notices it.
Yes.
Lifestyle is the leading answer
Yeah.
for most of our problems. So
Hmm.
let me turn the page for you and let's get into some blood labs. I'm going to
Yeah.
go one at a time
Okay.
in reference to insulin resistance, metabolic
Yeah.
syndrome, i.e., metabolic disease. Uric acid,
Yeah.
yes or no, and why?
So I don't use it a lot. I think like we could use that, and I'd love to hear your opinion on it.
Mhm.
If people are really inflamed and they have gout, obviously it's really important to measure. But I haven't found it to be a super helpful tool, like unless I'm just not looking at the right ranges, for
Mhm.
people that just have general metabolic dysfunction. So do you use it in your practice to
I
measure?
do because, according to David Perlmutter in his book
Yeah,
Uric Acid, which I checked, Drop Acid, good book too. I know he got
yeah.
beat up on somebody's podcast, but you know, let's not go there. Cheap shot, if you will. I think uric acid is a great marker because it indicates the number one reason why uric acid is elevated is from fructose. So
Yeah,
obviously, if they're taking too much fructose, that's going to
you can
pose an
see
issue.
that.
So uric acid goes
Yeah,
up, which I'll
yeah.
feed to the next marker. We didn't get to the good ones yet.
Okay.
I starting off slow.
Yeah.
Homocysteine.
Yeah, homocysteine. So yes, we do look at homocysteine on our metabolic panels. And so we're looking at that methylation when we're looking at homocysteine too. And so it tells us not only do you have we can look at your actual folate levels, but with homocysteine, we see, is it activating properly and are we methylating in that cycle? So we do look at that, and there's data that shows that high homocysteine is increased risk for cardiovascular events. And along with that, the methylmalonic acid, MMA, which is connected to some of the other B vitamins and B12. And so we can see, like, again, are you getting appropriate levels? Even, and I find people that B12, like if you actually measure like a plasma B12, there's a big wide range, right? It's like from like 200 to 1200. So adding in the MMA and the homocysteine sort of helps you see, like, is this enough for them? Are they methylating it properly? And sort of looking at both sides of the equation. Because so many people come to us and like, I'm MTHFR, they act like they're diagnosed with
Mm,
MTHFR, which it's not a diagnosis. It's
no.
there's lots of MTHFR gene mutations, but there's a couple that are more common to have insulin resistance if you have those genes. But the gene mutations are related to, and I'm not an expert on this by any means, but generally if you're heterozygous, you have one copy of one of the ones, like it's C7. There's two main ones that are checked
Right.
even at LabCorp. But most of the time, like if you're heterozygous, you're maybe going to decrease by 20 to 30% your production, not even of that methylation cascade. So people act like it's like the end of the world. Oh my goodness, I've been diagnosed with MTHFR. It's like, it's not a diagnosis. It's not a condition. It just means that you need a little help methylating, or maybe a little, but I think, and I don't know about your views on this, but I find that our like functional medicine, integrative medicine community, all these supplements have way too much methylated B vitamins in
Yeah.
them. And most people don't need that many. And especially because like downstream, there's other mutations often that some of these patients have in like COMT and things like that, that like when they take high dose methylated vitamins, they feel terrible. And so it's hard for me to even find, there's only a couple companies that have non-methylated B vitamins in their products. And a lot of times I think it's more of a marketing thing than an actual like clinical utility piece for a lot of places. So anyways, that was a side note, but yes, to homocysteine.
Homocysteine, a stroke marker, but also, like you said,
Yes,
A B vitamin problem with
yes,
methylation.
yeah,
Everybody should test for it. So, a couple of quick
yes,
genetic tests. Here's three. I'm going to make it easy for you guys.
yes.
You want to check your status, not if you have one of MTHFR. You want to see if you where your status of ApoE, especially if you have an ApoE4, and you would want to test for LP little a and cholesterol.
Yes.
Those are your markers. So I'm going to get now to some markers that you're going to want to light up on your scoreboard. Hemoglobin A1C.
Yes, so your hemoglobin A1C should be less than 5.7. So this is a 3-month average of your glycos. It stands for, it's like glycosylated hemoglobin. So it's that you have hemoglobin, part of your red blood cells. Red blood cells turn over approximately every 90 to 120 days. And so when we see how much glucose is sticking to them over that period of time, that gives us this estimate. So if someone's A1C is 7, which is a patient with diabetes, the average glucose is about 154. So there's a calculation of like what my A1C is to my estimated average glucose. But in reality, like people that are metabolically healthy should have an A1C maybe even less than 5 or 5.1, 5.2. When
Agreed.
it starts to creep up to, 5.6, we're starting to see, okay, we're getting close to prediabetes. The downfalls with A1C, though, are if people are going up and down, their A1C could look great, but they have, or if someone has sort of this, so sometimes people start to get hypoglycemic in the early phases of metabolic syndrome because they have this high insulin level. And so they have just this dysfunctional insulin as well. And so you could see their A1C looks like it's 4 something, but they're dropping into the 50s every time after they eat. And
Right.
so so that's where CGM, or continuous glucose monitoring, can come into
Love
play.
it.
Where, we can actually see what's going on throughout someone's day. I had a patient come in one time. She's in her late 50s, early 60s, and she's on estrogen, and she's working with an endocrinologist, but then she's like, I just still wake up with hot flashes. She's like, and she tells me this whole story about how she's eating saltine crackers and it makes her feel better. And I was like, saltine crackers are not fixing your estrogen problem instantly. So this is not a estrogen issue. This is
Mhm.
you're dropping low in the middle of the night, and saltine crackers are bringing up your blood sugar. So she was thinking that she was actually having hot flashes when in reality it was a hypoglycemic metabolic episode. And I've seen that over and over where people are having postprandial hypoglycemia is sort of this initial insulin resistance phase. There's also people that can have that due to history of bariatric surgery and other things, but so CGM is great for that. We can monitor your blood sugar for 10 to 14 days. People can access it on their own now. Both Dexcom and Libre have an over-the-counter version. They can just go and order, which is awesome. But you do want to be cautious on people that are really anxious, because if you're really anxious already, knowing all of that data and trying to like modify things all day long, like it can be a little bit overwhelming for that crowd.
Outstanding. I
Mhm.
wholeheartedly agree with you with the
Yeah.
hemoglobin A1C. One little add, I read some data that if you're 5.4 or more, you have brain shrinkage. So obviously the numbers you said,
Yeah.
5.2, 5.15.
Yeah.
Good luck getting under 5 as an adult, but I'll
Yes.
take a 5.2 or a 5.1.
Yeah.
You said fasting glucose before, over
Yeah.
100 to 125, pre-diabetic, over 125, a
Yeah.
diabetic. But you and I both know if you're 96 and you're
Yes.
25 years old, it's too high.
Yeah.
As you said, you want to be 70 to 85 waking up. Here's one for you. And a lot of practitioners don't take it. C-peptide.
Yeah, so C-peptide is one of the things we use in endocrinology to differentiate. So it's only on human insulin. So if someone is taking insulin from, injectables because they have diabetes, that's not going to affect a C-peptide. So C-peptide is our natural insulin that our body makes. And over time, so if someone has type 2 diabetes, they say that 50%, so when you get to that point where you're diagnosed with diabetes, where you have a fasting glucose over 126, most likely, again, you could be diagnosed with the A1C and the fasting isn't quite there yet. But if you have that point, they say 50% of your beta cells are already gone. Like you're only
Wow.
functioning at 50% of what you were before. And then over time, that continues to decrease. And so a C-peptide can see like what the like actual endogenous production of insulin is. And then fasting insulin is another piece of that puzzle. So we can see like that whole insulin molecule and see what the level of that is as well.
So here are our recommendations.
Mhm.
Uric acid, homocysteine, hemoglobin A1C, fasting glucose, C-peptide. I like a glycomark. It's just basically telling you your average blood sugar over a 2-week
Mhm.
period. And
Yep.
HOMA-IR, which is a great
Yes.
mathematical formula for insulin resistance.
Yes.
Any
Yep.
other markers, or are we covered it with that?
We can talk about HSCRP, but looking at so it's high HS stands for high sensitivity CRP, and that has been correlated with increased risk of cardiovascular disease. And often in our patients with blood sugar issues, we see that to be elevated. The hard part is it's not specific. So CRP is it stands for C-reactive protein, and it can be a marker that can be caused from other inflammation too. So if you have Lyme or other things going on in your body, it could be triggering that to be high. So, but it does, like, I think from a patient standpoint, it helps them to see, oh, wow, something's driving inflammation in my body. So sometimes I say that like checking labs isn't as much for me as it is for the person in front of me to
Sure, agreed.
understand why we're doing a plan. So even like omega-3 fatty acids, we can do an omega check panel at even LabCorp or different places like that. And I know their omegas are going to be low if they're not supplementing and not
Sure.
eating a bunch of fish. But when they see it on the paper, they're like, oh, okay, I'm going to take it. And so I think sometimes it's just like sort of putting that picture together for them to really like, okay, this is why we need to make this change.
Yeah, omegas are critical. Just adding 2 grams of omegas will
Yeah.
increase your lifespan, healthy lifespan by 5 years and ward off Alzheimer's 4.7 years. Before I let you go,
Yes.
my buddy, I always close with this,
Okay.
lives in Switzerland, and he says, Rob, I listened to the 45 minutes. Have the guest give me 3 critical takeaways in 90 seconds or less that I can
Okay.
implement on Monday for better health. The
Yes, for
stage is
better health.
yours.
So get those lab markers tested that we talked about, especially
Okay.
the fasting insulin, A1C, lipids. And then also, I would say everybody in America, maybe Switzerland diet is better, but everyone in America needs omega-3 fatty acid supplementation. And we all need our vitamin D checked. But most importantly, we really have to get moving. Like people have to start building muscle. Walking isn't enough in most cases to maintain your
Right.
muscle mass. And I think that's the part that we've missed a lot in our counseling of patients over the years. It's like, get that 5 minute walk, get that 15-minute walk. And yes, if someone's 300 or 400 pounds, that is a starting place, but we have to build muscle to be able to help improve our insulin resistance.
Outstanding. It's been my pleasure.
Yes. Yes, thank you.
It was a wow moment, the whole 48
I
minutes. This
know.
has been great. I know my followers are going to love it. How can they get
Awesome.
in touch with you if they want to follow you?
Yeah, so I'm at farm2table.life, and farm is PHARM for pharmacy. So
Chris.
PHARMTOTABLE.life is our website. That's my handle on social media. We have a team of clinical pharmacists across the country that are doing this type of functional medicine care and helping people look at their medications, but also the functional medicine process. So you can go to farm2table.life, book a discovery call. We have almost all the states covered. We're working on the last couple. And then we also have, for providers that are listening, we also have functional medicine continuing education. So it's functionalmedicinece.com. And we have a conference, which this may not be edited before then, but we have two conferences a year. So we have one this year in April and November that are all virtual. So it's super easy to join. They're
Right.
recorded if you can't join during the day. You can listen to it later. We also have on-demand CE that comes out throughout the year. And then next summer, we are doing a Mediterranean cruise. So if you're like, I need to learn more about functional medicine, but I also need a vacation, we are leaving from Barcelona in June of 2026 and taking a cruise to Malta, Turkey, two Greek islands, and ending in Athens. So definitely need to join us.
Outstanding. Love
Yes.
being involved with you. Thank you so much for your
Yes.
time.
Thank you for
Dr.
having me.
Melody, outstanding. Rob Silverman, Proven Health Alternatives, always yours in health.